So for Thailand, we have the subcommittee for development of the benefits package and service delivery. Then we have the health economics working group, which then determines the criteria for topic selection and prioritization. I think this is what we're talking about. Like for Kenya, we may be doing these things, but it's not very well defined who should be doing what, or some of the bodies that are supposed to do some of the work are not yet established. So for example, the benefits package and service delivery subcommittee formulates policy and strategy in the development of the package. The health economic working group determines the criteria for topic selection and prioritization. Then there's a working group on topic nomination that nominates the topics or interventions to be considered in the package. Then there's a working group on topic selection at academic institutes that then prioritize the nominated topics or interventions by using a scoring system based on the 6 criteria. I think there's a social health insurance regulation that informs the Act. Some of these scoring systems for HTA are attached there if you look at them. So we are somewhere, only that we now need to align all those things to come together. Then the health economic working group then selects a research approach. Are they going to use a model? Are they going to model? They're going to do systematic reviews and meta-analysis? Are we going to do primary data collection and or clinical trial, whatever it is? And then Health System Research Institute and Academic Institute develop proposal and conduct the study where needed. And then there's consideration of the presentation of the results after the study has been done, and the decision-making point, and how the National Health Security Board then onboards. So these are learning points. Some of these are already happening for us at different points. It's just to align them into our HTA process guideline. Then we should be able to embark on some of these things systematically. So we are not far off. Then, so this also shows, like, for the subcommittee for development of national list of essential medicine, how does that inform up to the policy level? There's the national experts working group who do the selection. Then there's a working group for coordination and consolidation of the essential list, who are also informed by the health economics working group that generates the evidence for them, and also the price negotiation for national list of essential medicine selection working group. So there's actually a working group on price negotiations who are informed by the health economics. So the health economics people will show, okay, at what price is this intervention cost effective if we adopt it? And then inform what price negotiations will go into that, especially for interventions that are purchased in bulk. For example, if KEMSA is doing the purchasing, they advise, for this product or for this drug, we should aim to procure it at nothing above this price or something like that. And then the subcommittee for development of the essential list gets informed by all those groups after that, after the evidence has been generated at that point. Then there's a working group for monitoring the different drug categories. So apart from the national list of essential medicine, there are other drug categories that may not end up in the list but should still be considered. They also participate in that process. So it's a whole learning process to the Prime Minister of Public Health for them, so probably the Cabinet Secretary for us, who then announces it in the Thai government gazette. So they gazette these decisions as well. So the process can differ by country depending on, like, what policy structures are there, but it's a good learning point for us as well. Then this just highlights same process. So that was for the National List of Essential Medicine. This is for the Health Economics Working Group. The working group coordinates and consolidates the National List of Essential Medicine. They gather information and make recommendations and give it to the Health Economics Working Group, which then announces to non-profit organizations to submit applications to conduct economic evaluation. So they actually call out to NGOs, academic institutions who conduct these studies to give them evidence for the health technologies that they would like assessed. And then the public institutes and non-profit organizations perform the studies. So this is for the health economics working group. They focus only on economic evaluation. So they will the working group will conduct, identify who will conduct the economic evaluations, and give that evidence to the working group for adoption, and also to inform the price negotiation and national list of essential medicine selection working group. So it's a whole intertwined web, and you can see the timelines between performing the economic evaluation studies and giving information to the health economics working group takes about 24 weeks, plus or minus. So some of those processes take long to be able to gather evidence, get the data, run the models, or conduct the studies could take a while. So it's not a request that will be given, today, and maybe you get some of the results next week. Some are faster, some are slower. So this is an example of the use of economic evaluation for inclusion of medicines in the Thai pharmaceutical benefits package. So when economic evaluation was conducted for a couple of medications, there are some that were outrightly cost-saving, and they were included in the national list of essential medicines. So they conducted HTAs to determine which interventions they will include in the benefits package. So the ones in green were outrightly included because they were shown to be cost-saving. Then there were others that were at borderline, just above the cost-effectiveness threshold. And they underwent price negotiation for them to be considered for inclusion. Some of those, for example, cisplatin for non-small cell lung cancer. You can see there nilotinib for chronic phase of cytomegalo. That's what? Chronic myeloid leukemia with the Philadelphia chromosome. Which of the two, with or without the chromosome, is shown to have a good prognosis? With the chromosome. Yeah, I think it's the CML with the Philadelphia chromosome has been shown to have good prognosis compared to the other one without. So when all those are considered, then you can do price negotiations, because if you introduce this drug to this group of patients who generally have a better prognosis, then you're actually going to save that life. So all the way that way, there are some that were more cost-effective, were not cost-effective or were not cost-saving, but were included. And there are other considerations that were made, including equity considerations and all that. And we'll be able to see that on Friday when we're doing the equity consideration session. So this shows how the HTA role in coverage decisions. So which ones were covered and how did they make decisions to cover them? So for different interventions, lamivudine or tenofovir for treatment of chronic hepatitis was shown to be cost-saving from the economic evaluation included, the year that it was included. Some that were not cost-saving and therefore were not included. So it's based on evidence. If someone asks you, why did you decide to reimburse for this medication for mental illness and not this one? You're actually able to pull out evidence and show how you arrived at that decision. That is HTA. Then HTA has also been used to define the pharmaceutical benefits package to provide affordable healthcare. So this just shows the price negotiation process. So tenofovir, during the economic evaluation, the price that was used, and at that time the market price was 43 baht. 43 baht is just about 150 Kenya shillings for the drug. Then they were able to negotiate the price to 12 baht. That's to about what? Less than 30 shillings, 30 Kenyan shillings. And the potential saving was massive, almost 1 billion Kenya shillings if you convert it, right? So, and that's just for one drug. So this just shows what price negotiation after generation of evidence can do for your budget. And imagine if we save 1 billion from our health budget, what else are we able to provide with that? So much more, and that's just from one drug, for example. So yeah, there's room for price negotiation through HTA process. HTA can inform those decisions for us. So, so some of the strengths that they've been able to capitalize on is the establishment of organizational structures for HTA, availability of legal frameworks and policies for HTA, increased availability of awareness creation, capacity building, policy interests in the universal health coverage, technocrats' interest in evidence-based processes, presence of international collaboration for HTA, and involvement of bilateral agencies. And we can see some of these things we already have, right? We have, although we don't completely have the legal frameworks and policies, there are actually things that are now able to inform and support the use of HTA process. Organization structures, hopefully that can align soon, but there is something in the Ministry of Health, right? Yeah, HTA process is, HTA is anchored in is it the Policy and Research Directorate? So there is something. Then capacity every day is a new learning experience. Hopefully we can have more and more of these sessions for the different groups that are involved in decision making. So we can capitalize on our strengths in that sense. What we need for HTA for Kenya, we still don't have the HTA process guidelines, the methods guidelines themselves, the cost effectiveness threshold. I think we're using the WHO. Are we still using 1 to 3 GDP per capita? Which has been challenged, challenged through publications, but we'll be able to see that. We don't have a quality adjusted life year value set, which needs to be developed and adopted. Currently, we are using for other countries if we need to make that decision. And we'll discuss the challenges with that when we're looking at health outcomes, I think on day 3. We don't have a unit cost menu that we need to develop to be able to identify what our costs are for providing interventions. Curriculum alignment, introduce HTA training in curricula of relevant postgraduate trainings. Ethical guidelines, we are talking about ethics and equity considerations. What is the ethics framework for HTA? That's something we need to think about, and also have databases for establishing a necessary infrastructure for HTA, databases, software tools, analytical resources. There's so much to be done, and I'm seeing so many people here. So if each person takes something, we'll be somewhere. But yes, all of us need to come together to realize HTA. So again, the opportunities that people have capitalized on that we can think about, they are improved resource allocation, evidence-based policy making, international collaborations again and again, and stakeholder engagement. If you want to do the HTA process and you leave out the stakeholders, you will be in trouble. You'll keep going back and being taken to court for the decision that you have made because you did not involve the people who are going to take you to court eventually. So challenges, we've talked about data availability, and we've highlighted that as a challenge. On my side, I actually believe we have a lot of data. Sometimes we just don't communicate it, or we don't know where it is. But when you start to talk to people, you realize how much data we have that we can use to make decisions. And if we are able to collate it or have it in a structured way, then we have all the data. We collect the data as Kenya at so many levels, and we are able to use that data to make decisions if we know where to get it. Then the other challenge is methodological complexities, and we will try our best this week to demystify how complex HTA is. I believe it's not as complex because everyone has their role. You don't have to do the epidemiology and do the economics and do the ethics issues or social impact all by yourself. If everyone is able to do their bits, we are able to generate evidence that is required for HTA. So some of the issues that are being explored for HTA currently include digital health, health security, precision medicine, antimicrobial resistance, environmental health, impact evaluation of technologies. So public health interventions, there's so much more that is now being used, HTA is being used and adopted to make decisions on. So in conclusion, we need to invest in HTA capacity, allocate resources as we do our budgets, allocate resources for training programs, support the establishment of dedicated HTA units, integrate HTA into policy making process, promote stakeholder engagement. Over and over again, I will not say this, I will not tire to say this. If you want to start the HTA journey and the HTA process, map out your stakeholders. Know who they are, know when to engage them, where to engage them, how to engage them, and have a guideline on it. Encourage active participation of stakeholders at all levels. When defining the research question, when interpreting the evidence, when deliberating on policy, implications and all that. And support for data infrastructure and evidence generation is important. So this just also, we can make a call to action from where we sit. I'm sure we are able to influence some of these decisions to align the health system goals and priorities by ensuring that HTA activities are aligned with broader health system goals as well, and advocate for evidence-informed decision-making. And I'm happy that when I'm talking to DHPT, the head, and all of us, we are all seeing how valuable and how HTA can solve some of our problems, especially the questions on how we arrived at a decision and why we left out some interventions. If we go through the HTA process, it will be explicit, it will be transparent, and anyone who asks the how and the where and when will get an answer for it. Thank you very much. I welcome any questions. Before we move on to our next session. Any questions? That's just an introductory, and if some of these things are not clear, we are going to delve into them in the subsequent days, and we will be able to know.
Maybe a question.
Yes.
The work around AMR, maybe just, I think the earlier presentation on SEMA
Okay.
by her and what you also mentioned had an element of, I think in your thematic areas,
Yes.
there was an area around AMR. Could you maybe just give a bit more info, the nature of work around that, so that we could also, because we have some work around AMR also ongoing somewhere else.
Okay.
So it would be interesting to know how you
how it
yes.
it aligns.
Yes.
Okay. I think there's so many different things going on AMR. What Dr. Jared is asking is on the clinical trials that I could talk about the HTA bit that we've done, but I want you to talk about the clinical trial first, like the research that is going on, and then we've done some HTA support for AMR as well, so I'll talk about that.
Okay, so Dr. Jared, sorry, I'm not on the AMR team, but it's always assumed that I know something, so I'll speak what I know. So for AMR, the surveillance that's ongoing across several health facilities, and SEMA supports lab capacity, as well as the development of an antibiogram that's available online. So we can share the link. You'll see which sites are submitting samples, the most up-to-date antibiogram. I believe that's what we have. For any other work, I'd have to get in touch with Dr. Christine, who leads that work. Yeah. So I sent you the link to the Shiny.
Okay. Thank you, Dr. Jeanette. So apart from that, for the HTA process, I think most recently we had to support the NASIC team, the National, what's the long for NASIC? But the
National Antimicrobial Stewardship Interagency Committee.
Thank you. Yes, the one that is doing One Health for AMR. Yes. So as part of a wider activity that they were doing, I don't know if I'm in a position to talk about it. I'm not part of the MOH, but we were able to support them to prioritize the interventions that they were going to look at for that activity. So sometimes you have 100 interventions, you have 1,000 medicines that you need to look at, but you're not able to review, even like do a HTA process on all of them. And HTA process or economic evaluation process, for example. So the HTA actually provides you with a priority setting mechanism. So how do we even prioritize the 100 interventions that we want to do an economic evaluation, or the 10 interventions out of the 100 that we are going to do economic evaluation on? Also, we don't just make noise. We use a tool and a criteria to decide that these are the 10, because these are the criteria that we agreed we are going to prioritize, and we score them. So that's what we help them to do for HTA. Yes, and that can be applied across very many different sectors as well. Yes, thank you. Yes.
Yeah, thank you for that elaborate presentation. Well, I sat here listening. It came out that HTA is heavily dependent on two things, data and information, especially when you're highlighting the gaps that you saw during the, I think it was benefit package. And you referenced, I saw an example was mental health. But now, I'm just trying to understand how it would be, because I'm sitting here as a policy maker. One of the biggest challenges is the availability of data. We know it is out there. I can give you an example. Parliamentarians needed to know number of people who require hearing aids. So the assumption there is we as MOH know number of people who have hearing loss. But then we realized even that indicator itself is not available. So therefore, if you are to get that data real time, it means you have to make phone calls, you have to contact the almost 14,000 health facilities of 47 counties, and you're required to cost within 2 months. So you realize you'll end up spending the amount of time collecting data, and you're required to give an output. Because most MOH people here will tell you, most of the time we do crisis management and damage control.
Yeah.
So that tells you, it goes back to what the executive order wants, the mandate of the ministry, parliamentarians, and what's in your desk. But you have to cost.
Yeah.
Burden of mental health illness. If you are to know proportion of population who have, let's say, schizophrenia, within seconds, you see it becomes a challenge.
Yeah.
You go back to the indicator, you realize even KHIS has lumped everything.
Yeah.
But you need it to get population need and current coverage. So you come up with a package. So is the main issue HTA, or you have to put some things in order before you even think of HTA? That is what I was grappling with. Thank you.
Okay, great. So I was showing this because this is what you are referring to. And as part of the costing the package, the step 2, down there, I think I talked about secondary data for an available cost. Like, I was thinking, as that presentation was being done by the health financing, I was asking myself, like, if we don't have the costing data, or we've not costed for Kenya, have they considered, other methodologies of costing? And we are going to see, day 3, what other methodologies we can use for costing. We don't have to collect primary data to cost. The secondary data that we can use from our neighboring countries, from abroad, and there are methodologies to adjust those costs to fit into our country. So that is possible. But the other thing that you're highlighting, which is very important, which I said here, and you've summarized it very well. What do we need for HTA? Databases. Critical. We have this data, but they need to communicate to us, and we need to know where they are. So we need to establish at least databases, software tools, analytical, all those things that we are able to even show. If I've done costing, there are organizations that have done costing for certain diseases, but where is this information readily available for us? If myself, I come into the DHPT today, and I don't know what has happened previously, am I able to maneuver and know where I can get costing data for HIV, for example, for TB, for malaria? Those costs are there, they've been done, but now accessing them that's the next conversation that maybe needs to happen. But yes, I appreciate that you've actually noted that. I think in the interest of time, one burning one.
Fine one, thank you for that informative presentation. I'm looking at the aspect of governance structures supporting HTA in Thailand.
Mm-hmm.
And the issue of price negotiation is coming out very well. It's impressive to see that decrease from 43 to 12.
Yes.
Now, when the 12 is gotten, is this 12 from manufacturers or is it from distributors? That price, is it what now the insurance pays, or is there a markup? At the end of the day, how do you decide the paracetamol which is not going through maybe the HTA, the price to reimburse at, and when you get that price that is negotiated, when it goes to the facilities, at what price, at what point is that price? And are there markups maybe allowed? How will we get to know how much we reimburse for the medicines we get in our pharmacy benefit package? And where is the pricing committee maybe located beyond just the negotiation team? Thank you.
Okay, so for most of the HTA work that is done by a semi-autonomous organization that is part of the ministry, but semi-autonomous. So they get their funding from non-profit organizations and they're able to do this work. That then informs the ministries. It means that the ministry then requests for evidence as part of the purchaser. So that could be like the government pharmaceutical. They actually have a whole government pharmaceutical manufacturing by itself. But there's also drugs that are imported. So like at that importation point, because these drugs are being provided under the UHC and people are not paying for them, it means that the payer is the government. So the person who needs to negotiate for that price, to get it at that price, is the government. Once it gets to the facility, we don't need to talk about any other price because the facility we are already, and for their UHC, the service provision is through the public. So yes, only. So once the government negotiates that price and whoever is applying that drug for that amount, that's what the government pays for. And everyone is not, doesn't need to pay for it beyond that. So that's why it works. So that's why I was saying, like, these processes, we'll have to adopt it to align with what we have. Yeah, challenges here and there, but they can be surmounted, right? Yeah, all right. Thank you for your time and for your attentiveness. We are trying to sort Dr. Asare. He has joined, but he was saying he's not able to hear if people are. Good morning, Dr. Asare. I hope you're able to hear us. Are we able to hear him? So as you sort that out, I'll call Dr. Mwai probably to give his session. Karibu, Dr. Mwai, we are honored to have you here. Dr. Mwai will take us through the HTA infrastructure for Kenya, where we are, and what policy says. Thank you so much, Karibu.
Hello. 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 Can you hear me? Hello. 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 Hello.
So I'm a health economist.
Okay, I can
a
hear you now.
lecturer here. You know, people usually see me the other side. They don't know I have a home. So this is where ideally I originate from. My work is very simple. I think it's just highlight where we are as a country vis-a-vis where we ideally want to go. But I want to highlight that in the other type of work that I do as an advisor to the President on health, you have seen quite an elaborate push to really use evidence and data, and more importantly, the technical people, for their voices to be heard, and what they have ideally conceptualized for a long time in books is actually captured. I think that is the attempt. You obviously know that in government, you appreciate baby steps. So you do not wake up one day and the whole system is HTA compliant. So you'll have teething problems. You struggle with them for some time. But I say if we believe in it, and I do believe that if you are a technical person, you must believe in that, in what you know how to do, So if you are a HTA expert, do it. If you are a HPT expert, you need to do it. So I just wanted to highlight that it is with great recognition that we know that the main reason why Kenyans bypass healthcare facilities to go far or even defer treatment is lack of commodities. So that sits at number one. The second problem is, of course, lack of human resource to diagnose you so that you get the medicine. So sometimes even when the medicine is there, you don't have someone to actually prescribe, and therefore you not go to that facility. The last one is lack of diagnostic capacity. Now that diagnostic capacity is actually closely linked to health products. So I tell Akiba, because I've seen him here, that this HPT is very serious. That if we can get a way of resolving it, not only from financing, but also enhancing the efficiencies that the system can give, then we can do more with the little money we have. Because money is always not available. Hata kwako pesa haikutoshi, right? You are still struggling. Your salary is moving at a slow pace. Your expenditure is running. So zinafukuzana hazishikani. All right? Unless you are very lucky, madam. All right? But what is happening in my case, you can come for learning in case yours is different. So that still happens within healthcare implementation context. So we keep saying we need to do more and more and more. The money becomes less and less and less. And even if we added more money, that money is still not enough. So I think then this becomes a very noble team, more so because the other thing this government is trying to do is reduce the cost of care. Now, I have lived my life as a health economist doing costing. I think from the first time I started my career, that is what I've been doing. I have looked at costing healthcare financing, And we know that the largest component of treatment is actually HPT. Now, if we continue to get these commodities at high prices, then we will not be able to reduce the total healthcare expenditure, which now stands above 550 billion shillings annual, which is the biggest for any sector we have in this country, And then when we look at health indicators, they are not moving at the same rate as the money. So the money usage is increasing, but indicators are not moving. So there must be a problem in the way we are either prioritizing, or the way we are targeting, or what we are buying. Now that's where the work of evidence becomes important in informing decisions. So I just wanted to highlight that the key important thing that we need to look at is how do we then have an institutionalized process that is able to guide the decision we take as a country on what to recruit and what not to. Now, currently, because we have political goodwill, we need to set up the system so that in the future, the system can stand on their own and be able to do this work we are discussing, so that the people who are good in management of commodities, in supply chain, they get a place where they can be able to bring their issues and they can be able to advocate for them. The issues of efficiency, as I have just highlighted, we we run a healthcare system that is completely unstandardized. So pooling become very difficult. So we don't know who is consuming what, where. And even if we do, we know much of public, we don't have private. And even with that, we cannot control what they use. So then that tells you why we are very much interested in the digital system. Because within the registries, we need there to be a terminology registry. Inside the terminology registry, the expectation is that there will be formulary. So that we are able to standardize what we are using. We can study consumption, demand, and those processes. And therefore, as a country, we can be able to pool orders and negotiate for better prices. There are countries that are worse than us, like Sudan. No, you know Northern Sudan at some point. It is not Northern Sudan, it's Sudan, right? Where Khartoum is. They came benchmarked here. Their KEMSA is a benchmark of Kenya, right? Then they went implemented. They pulled their orders for NTDs. They get better prices than we do. All right? But as we are struggling, with each visit costing almost 100,000 of an NTD, where will Kenyans get almost $1,000 every time they go for a visit? So it is us to think. So that, Nancy, by the time you leave, one thing you'll be saying is that we reduced the prices of commodities from this to this. Whether you earned anything or mileage, that doesn't matter. But as a practitioner within this area or specialization, you'll have been happy that you did something for your country. And of course, the last thing is that you want better outcomes, and we also want our indicators to look better, and that is where we are in terms of objectives. So then this becomes important to continue doing the evaluations of the processes that we are using, to provide evidence for the same, to promote the efficiency allocation in the areas that we actually believe in, and also to improve the access, and then we also have better, economic coverage for people. So ideally, this is a process that should happen. All right? Is it happening now? In an haphazard manner. You find there is a costing team for benefit. That one is trying to work, but it is not working. If those people are transferred, let me tell you, from the ministry, because or SHA. Right? Do you know there is nobody with history? That is a problem. Now, for us to make sure that we have entities that can carry this work beyond individuals. You see, like if my laptop is stolen on the costing for this country, you will use the data on financing we will lose is not stored anywhere. So it is living as long as I'm living. Now, that's a very bad way of running a country system. Now, what are we saying? We need to institutionalize this information in a way that is available and it is shareable when it's needed. I'm sure the HPT guys, because we have suffered without them until we had to look for some individuals here and there. When they come, they have this information. So we realize, it's not me, my problem with my laptop. It's a common problem. All right? So we need to deal with this common problem in a way that we structurally provide for a way we can be able to make our decisions. And as we make these decisions, we are able to engage our policymaker. So for my biggest part of life, I have lived as a researcher and evidence generation guy. So after generating, I say, good Lord, please push this one, right? Now, from where I look at it from now, I actually think I should have been a little bit more knowledgeable earlier, because it's easier to advocate what you have already generated. Now, if you get a light ear, then it is possible to push that into policy, so that what you has generated is actually used for policy. Now, then I ask myself, how many people will get the right ear? Right? Those people will be very few. Therefore, if we institutionalize, then even if you're not getting the right ear, the ear can look for you. Because sometimes the health, ideally talk to itself many times. And that is why globally, if you go for all conferences, the people you'll find there are the people you see anywhere, in any other conference you go that is related to health. That means we are still a close-knit system where if you are in the health sector, you are in Kenya, in the countries within this region, what happens is that we rarely cross-pollinate to the other policymakers. Now, you realize that decision to allocate money has something so little to do with health. So health will say health is important, we should allocate money, we should do this, but health does not allocate the resources. So we are left with trying to talk to people to allocate money. Ideally, they don't listen because the language we are talking and the one they are talking is different. Unasikia daily averted, quarries, years of life lived. What are those things? Surely. Where another person comes and say, if you build this road and put tarmac, right, you know that the return will be available as 25% each year. Now, if you don't want to overthink, which one will you take? Even if you are there, boss. Right? So it is not also about what we are saying, is how we are saying, and also who is saying it. So within this decision-making, ecosystem, we have the policymakers who should make the decision. If you don't give them the right information, they make the decision with the information they have. They'll still not make it. I want to highlight, there is a time when, after devolution, the money for buying ARVs was devolved. For those who remember, just after devolution, I think you could remember. So when the money was devolved, it was sent to the counties. Now, of course, the counties, when they receive the money, it's a part of shareable revenue. They allocated it to cablos and the big gates. All right? Now, that time, the health sector is talking about stockouts of critical medicine, life-saving medicine, essential. You use all the words that you can use to make sure it is looking important. But the person who received the money summarized all your information and bought cablos. Now, you think that person is crazy. Probably they are. All right? Now, but when you come back, you realize probably that is what they would understand as the priority of the county. Because they are not even remembering, they have almost 300,000 people on ART. They are hoping that manna will come from heaven. Now, that is what happens when there is this kind of confusion. So, in this decision-making process, is a non-linear process, but we can try to linearize some areas so that there is a sequence of how things do happen, who is involved, so that anybody who wants to communicate also get the right information to communicate. Because you have no control of who says what. But you have control of providing what they can say. So that if they are well-wishing or they mean well, they would pick the right information and communicate the right information. Like the way we say we are providing free health care. So when we say provide the free health care, there is nothing free from where I look at it from. Somebody is paying. Because a donor is paying and you say the free, when you go to ask for donor transition resources, somebody is not understanding why you are transitioning free things. All right? So it's also how do we look at how we communicate and set behavior, like within our system, within this framework of decision making. I've seen my friend there. There's a time somebody transferred the money for vaccines. Recently, is it true, madam? Money for vaccines was removed. So when you remove money for vaccine, you wonder, is this person mad? But when you ask them, they are saying, we had a salary deficiency, and we saw this money is lying idle. What is this resources lying idle here? We transferred it. So that tells you that it does not remain enough for the healthcare sector to understand the importance of vaccination. There is another person somewhere who might actually mess you up big time because of not having a structured process. So I think you understand why the institutionalization process, we are trying to see how can we institutionalize this decision making going into the future. So ideally, I'm just saying that the terrain is a little bit more open. We must agree on how we move this into perspective. Now, within our haphazard, non-structured process that we have, few things are happening in this country. One is, of course, the discussion on risk protection, which is where you hear a lot of social health authority, shisha, SHU, whatever, I don't know whether you know what those things are. But ideally, there is discussion on social protection. How do people access healthcare without incurring, financial strain? Simple as that. With that, that is where we have the Social Health Authority that holds three funds: the Primary Healthcare Fund, the Social Health Insurance Fund, and Emergency Critical and Chronic Illness Fund. So that is discussion that is happening. It is happening as usual without a laid out structure. Actually, if people are to be asked, how can we do this again? There will be a lot of problem. Because there is no even recording on how we have gotten where we are. We have just found ourselves, kuna committee moja hapo, ingine pale, another one here, but we have moved, all right? But it's a discussion that is happening. The issue of determining the value for money for health is also a critical component of what is happening. Have it been done well? No. Do people want to implement cost-effective interventions? Sometimes yes, many times no. Because you'll find the private interest sometimes drive you to cost-ineffective interventions when there are others that are more effective. All right. So the analysis of cost effectiveness in this country is also very low. Even the people to analyze are extremely low, few in terms of capacity, right? And for a long time, it is only myself and Dr. Kyoko Albanas who had the ability to do cost effectiveness analysis. So when I say this, I'm just saying it's a gap that have been there for a long time. So people don't want to be seen to be saying this intervention is not cost effective. It has no value for money. But if you start saying it on your own, again, people can label you as you don't like this intervention. So again, the call for a structured process of doing that. The issue of affordability in terms of what can we afford or not. If you come to my household, one person, like madam, right? If you visit me home, I can give you a 5-course meal when you come to my place. Okay? I will plan to invite you at some point, probably. Now, when you come, all of you, most likely, if you get 2 courses, then you should count yourself lucky. Because there is always some efficiency that is lost when you do scale up, right? There is an issue of what I can afford and what I cannot afford. So when you listen into the current discussion of the benefit package and where NHIF went long, is it decided on a premium by guesswork. All right? 2014, I was there, so I keep remembering you were in Mombasa. I was a little bit younger, and I didn't want politics. So somebody said we are moving from 350. Somebody said we moved to 750 per person contribution. And the other one said we can be somewhere around 500. Then they said 500 is looking a little bit in the middle. So let us move to 500. So we shifted premium up to 500. I tell people many times, as rudimentary as it is what happened. Then we have tried to make policies to fit and tell people of stories of things we will provide and benefits from here to I don't know where with money that we will not lease. Now that speaks to the affordability question. So the actuaries tried to work back. Ideally, it should be the other way around. that the benefit that is being provided, you should know if the money will fit in. If it can't fit in, promise what you can provide. It's as simple as that. You will not be happy. Oh, you have not provided for optical, or you have not put dental, you have not, all things. When you talk to every specialist in the healthcare sector, the area is emergency. So with the optician, that is where you should put our money. Dentist, or money. Women and reproductive health, put all your money there. So the idea is we must get a way of knowing as our affordability increases, then what do we bring on board? Now that discussion we must agree to have, so that we also have a plan of how do we, continuously enhance the benefit package in a way that we can afford it, right? So these are some of the issues that are important for me to highlight. Of course, the issues of equity and ethical implication. I highlight again many times that if we are in the current NHIF, it is a regressive system. A regressive system is a system where if you are poor, you pay more. Our tax regime as a country is progressive. That means if you have more, you pay more. So our NHIF as it is, if you are earning low incomes, you will pay as high as 5% of your income. Employed, I'm sorry, talking about non-employed, because people sometimes talk about theories. The people who are employed currently, the lesser income you earn, the more you actually pay. So that goes a high of 5%. Now that amount percentage drops. By the time you get to $1 million, you pay 0.017. Now that is so, I have no words for me from where I look at it from. That's why when people complain of the 2.75, I don't understand them either. Because this 2.75 was ordinarily not supposed to increase the correction. It is supposed to equalize the people, so that nobody pays 0.017 and another one pays 5%. All right? So these are discussions that people should be able to interrogate within the context of social justice and equity if we are running a social system. So that's another issue that is important for us to look at. Of course, the other things require supporting environment information, and also importantly, scanning the horizon. You have to look there ahead, see what might come, which is new technology coming. I'm hoping that that is what Akiba is doing, right? Which are the new treatment approaches coming that is looking a little bit more cheaper than the one we are doing. Who does that for our country? Or we wait until lack before us? Or until the whole of the globe moves, then we move. Right? So we should have a methodical way of scanning the horizon to see which other better option can we adopt. And if we adopt it, what does it mean to our systems and to our procurement systems? Of course, the legal registration framework ideally is key. And I want to just make 2 points on legal registration framework. Countries that are well developed ideally, they have started moving away from guidelines, because guidelines are very good. You release a fantastic guideline. When you read it, you are happy, but you have no way of enforcing it. Like you read your HPT guideline. The HPT guideline is very good. Have you read it? Who have seen our HPT guideline? The strategy. All right. Now, when you develop a strategy, how do you enforce it? Okay, if the government does not follow you, what do you do? As a Akiba or a Nancy or whoever working in the HPT market, you are powerless. So countries are moving towards establishment of legal frameworks to guide the implementation, so that even if it's not Nancy going to force the government to go that route, somebody else will somewhere through the court system. Right? So legal frameworks become very important. And that is why for me, I still believe that the 4 laws that have been passed and one that I miss, which is quality of care. These are groundbreaking legislations because they are shifting from our way of strategies and guidelines into a legal framework through which somebody can hold government accountable. Or you can hold the waziri, the PS, whoever is there accountable, because it's enshrined in the law. So we need to look at how do we make sure that our processes are put in there and they assure that they are actually highlighted. So I would think that we do believe that we will create a framework that brings together the right process of identification of key issues that we need to look at, how they are actually prioritized, how do we assess of their importance. You know, there are people who have a way of over-exaggerating their own need to look very important, right? So they'll tell you this is critical. If you don't do it, you are finished. But when you scan around, it is only a problem to him or her, right? So you must have a methodical way of understanding what's the country priority. You know, earlier when the systems used to work more functionally, when you go to a county and you take a CIDP, for instance, it captures the agreeable priorities of that county. So that's why you begin from. Now, for us, we need to get a way of getting a quick assessment and appraisal of these important priorities to make us, you know, get the country to make the right decision. Right? So, and this decision would relate definitely to the type of commodities we should consume, you know, the benefit we should provide, the systems we should lull in, the human resource we should use. You see, when I see a lot of fights between cadres, sometimes I don't even know which one is better than the other. You know, for me, I need a good service. So you find there is pharmacist. The other one is farm technologist. Farm tech. Yeah, those ones are always in taekwondo, judo, karate, every time. All right. So I asked myself, why can't these guys just come together and just agree? How do we do the work? For us, we are interested to find that the right person prescribes, the right person, the right medicine is provided, the right healthcare outcomes comes out. These are now whether you are a president of whatever farm tech, whatever technologies. For me, they are irrelevant discussions. And that is sometimes, I have told them to their face this. Then we go to lab. Lab also have the same kind of problem. Right? They said lab technologist, and there is there are several there. So what we need to look at, we need to get a harmonized way, surely, to discuss these things. The achievement is not going to stop a registration in parliament, for instance. Who wins? None. This one goes stop. After this one leaves, the other one stops. All right? So you relax and say, those ones, let them fight first. Right? So we need to get a way of having dialogues and agreeing on issues. All right? As professions. All right? Before we take it to the political class, who will not use logic? They will use who have come. How are they? How influential are they? How is their pocket? Is their pocket well liquid? Who is paying who? These are also conditions that you'll find outside there. So before you go out there, it's good for us to rethink and have a methodical way of agreeing on these issues. So I think the key issues that we must all agree is that HTA is a good process. HTA is country specific. HTA should be created by us. Right? And I told Nancy another day, the people who move policy in a country, I have discovered, are very few. Actually, you can move a policy alone. So one never feels like you are not. You are not enough. Right? Now, if these people in this room would decide that this is how we will move. We will not move. But I've also seen the health sector have a way of thinking somebody will pick my idea and move with it. People are not interested with the idea because they have the years. They will only get interested with yours if it starts succeeding. All right? Now, so you must devote yourself to push it up to a place where it will start succeeding. Then even those who are opposing you, you will find them in a meeting early in the morning, saying they are the ones who have been pushing. Okay? I see that every time. Now, if you come from where I come from, it is not the fame you get as a person. It is the deliverable you give that gives you gratification. So, what also people do, when they see other people have gotten interested, you retreat now so that they fail. Then you come back to try and reignite. By the time you come back, people have lost hope in that thing. So you go back to zero. So what am I saying? I am saying that it is enough for one individual equipped with knowledge and facts and patience and resilience to actually change a system. I actually believe it beyond reasonable doubt, right? Because I've seen it happen, right? But you must be armed with facts. And you should be willing to give those facts, all right? I have actually seen sometimes politicians don't give you that. That political will may not be there. But it is also built over time. People start saying, if he says that, he's not guessing. Right? Because if you go to comment on everything you know, then you lose it. But if you are pushing what you know and have your facts, they will throw you the first day, the third day they will fail, they look for you. And you tell them, it's what I had said. And if you want to go right, go look for that man. Is usually found somewhere in a small basement in MOH, all right, with a small computer. That man can tell you, he's a technical person. So you will not say, I am the one who know it, but refer the people to the right people. I have seen that working over time. And for the last 2-3 years, I have seen it work. So it is important to try and equip ourselves with the right information and able to address the challenges of the future. So I will not go through other bodies, but you know that there are HTA bodies all over, and I'm sure people who have interest will be able to see this more. We want to create ours also, so that it will be this chart at some point. And we will be saying that this meeting that happened on 2nd of September is where we began our journey on how to streamline these issues. So that is exactly what this is all about. And I would say that it is important for us to all work together, whether you are in private or in public. You have a role to play in this system. It is important to say and know that there is always some evidence existing somewhere. When you are struggling to know how can you deal with a certain issue, I tell you for sure, there is a technical person somewhere existing within the system who does exactly that. And sometimes they are so below the surface that you'll never see them unless you agree to go look for them. So that is where you find there are some division heads, there are units. Units are below divisions. Yes, there is a small unit somewhere that is doing a very good work, but nobody takes them out, right? So when you go down to look for them, I can tell you, you'll answer your question in a way that it will not leave doubt, right? So it's an issue of also identifying the right skills, the right capacity, where it exists, but where it needs to be built, then you should also be willing to do the same. Of course, that says that we need to have evidence generation experiences. Our research should be, with the great integrity. You know, there are the people who used to say they collect data chini ya mnazi. When you send them, the tool always comes complete. But they don't, when you ask where they are purporting to have gotten the information from, you don't know. They sat down below a munazi tree and they filled, you know, this one look like if it were me, I can say I have been eating beans. Eh? The other time, this one meat is very good. I have been thinking of eating fish. So they complete your tour and bring it to you. Then you analyze your data and you make policy. Then you get garbage in, garbage out. You know why this country had ever emphasized on education for primary school? The World Bank paper was very clear that the highest return to education was primary school. So the government moved all its resources into primary. When you finish, you should not care because you have already reached where you earn more. So why would we care from secondary, university, you know? It's not important. But somebody sitting somewhere just did a research which was not good, so to speak. He did not control for the right things. He had not looked at where the country was coming from. He has not looked at the population we are talking about, the old population. Very few people had seen high schools, right? Right? So the population he had corrected was of many primary school, people who had attended primary schools. So what am I saying? I'm just saying that integrity, transparency, inclusion, and also accountability of these works that we are doing become very important because it can be a very small thing, but have macro effects into people's life. So those are some readings, and I am done. If I have talked too much, please forgive me. It's because I'm usually paid to talk. Asante. Sorry? Yes, Dr. Okechi is in charge of that one. I think she'll be sharing. Right?
All the presentations will be shared on the website. Did you share the link with everyone? Yes, it's on your emails. So anything that is not uploaded, but I think this is already uploaded, will be uploaded as soon as the session is done. Thank you so much, Dr. Mwai, for your presentation and that session. We'll move on to the next session.
I can take it. But you need this guy.
Burning question or two for our online session. I think Dr. is also on standby. Any questions? Very well presented. Dr. Sari, can you hear us? Can you hear me?
Hello?
Can you hear me?
Yes, hello. Can you hear me?
Yes, we can. Welcome to Kenya via Zoom. We are honored to have you share with us your experience for HTA today. Dr. Brian works at the Ministry of Health, Ghana, at the Pharmacy Directorate, and I had the privilege to meet him at one of the HTA sessions, and we had a good discussion. I was very impressed by the kind of work that Ghana is doing on HTA and the kind of enthusiasm that I'm also seeing in Kenya. So what better people to learn from than the people who are already walking the journey that we are looking at walking? Kindly, Dr. Brian, share with us what you have for us today. Karibu.
Okay, thank you. Can you see my slide?
Not yet. Yes, yes, we can. Kindly.
Okay, thank you so much. Yes, I'll be talking about HTA in Ghana, and I'm happy to have heard the various presentations from my other colleagues. If at any point you are not hearing me well, just prompt me so that I can ensure that audible. Now, especially in our country context, we have a lot of challenges with respect to the financing for health. And if you look at this chart, the same thing is in Ghana. And I'm sure a lot of African countries also have similar contexts, and indeed lower middle income countries in general. So we have an existing communicable disease burden, and then we are adding on top of that the non-communicable disease burden as well. But if you look at that, you realize that the communicable diseases, they used to scale in the population in terms of numbers. But then when you come to the non-communicable diseases, you have longevity with individuals who are with these ones, and the cost also follow that same format. So it's more difficult to bend the curve for expenditure on non-communicable diseases. It takes a lot of time to be able to see that in real terms. When you look at our funding too, our funding is also having a lot of out-of-pocket payments, which we are trying to avoid. But you can see that domestic funding is at a certain level, and we hope to be able to increase that. Hasn't been easy over the years, but we hope to be able to increase that. And it is within especially the domestic funding where we want to be able to optimize. And by that, I don't mean that any other sort of funding does not need efficiency, but at least because we are setting up governance systems, the primary focus on the low-lying fruits is to be able to explore efficiencies within the domestic public funding. So Ghana tried to set up a clear agenda for the UHC, all people having timely access to health without hardship, as we know. But there are systemic challenges. We are talking about low funding at 20% of NHI resources spent on primary healthcare, for instance. We are talking about regular stockouts at 40% of visa drug availability. We are talking about poor mix of maldistribution of critical health personnel and all that. So the challenges are many. And the question is, how do you prioritize, even in addressing bottlenecks in the system? What kind of challenges should you address to maximize your investments in addressing systemic challenges? And it is not just a question about efficiency, it's also about a question of being smart in terms of policy and in terms of what you actually address first before the other. So we find priority setting a big tool and a big instrument for us to be able to do this kind of system level priority setting. And then we, of course, we know priority setting to be the process of showing a limited health budgets, which I have shown you in the previous slide, are allocated to the uses of greatest value. And to do this at the system level in the health in the health sector has a lot of issues. And there are considerations. We need to look at optimized resource allocation. We need to look at informed choices. We need to look at trade-offs. We need to look at the principle of constraint maximization. I will explain that later. We need to look at how we can use criteria. We need to look at the perspectives for value judgments, and I will bring HTA. It's a great tool for decision to use HTA to achieve this. And in HTA, we have several dimensions of analysis. We are looking at effectiveness. We are looking at economic evaluation. We are looking at ethical, social, and legal aspects of analysis. And we are drawing this from the UNETA core model for HTA. Of course, if we're talking priority setting or we are applying this HTA that we are talking about, in terms of what we analyze, and to use that HTA in the context of UHC, we are talking about financing health, but it's not just about it's also about populations that are being covered. It's also about the services that are being covered before we even talk about the costs. Now, if your blue box in there, which is your funding, your pooled funds, are constrained, Then you realize that you cannot change all three dimensions at the same time. You cannot increase services, increase the population, and increase without increasing the amount of money that you have. And all of these health system building blocks are then relevant because in each of these service delivery, workforce, health information systems, access to medicines, you need to actually set priorities. And we hope that we are able to use HTA efficiently to do that. How did we actually set up HTA systems? And for Ghana, these have been the various dimensions. We needed a clear agenda. We needed some governance structures, some strategies, a clear sense of direction. We needed some processes. We needed some capacity build. We needed to produce these HTAs and we needed to apply the recommendations. We needed to monitor our performance. We needed sustainable funding. We needed also to do a lot of communication around this. And we are exploring how legislation can also assist. So for clear policy agenda, we had to actually leverage our medicines policy to be able to establish HTA because within there, we could have clear data, we could have clear application opportunities for HTA to demonstrate its impact. So we set up HTA this way. We had a secretariat, we had a technical working group, and we had a steering committee. Of course, we had a lot of partnerships. We had public and private sector stakeholders, but it was established within our state governance systems. And what do I mean by it was established within our state governance systems? This is the organogram of the Ghana Ministry of Health. You have the minister, and there are agencies at the top right. All these are agencies of the Ministry of Health. But within the Ministry of Health, you have line directorates in green, and then you have this blue box here for technical coordination. And then HTA was located within the technical coordination because it aligns with what the technical coordination does. This technical coordination actually provides technical support to all the line directorates and agencies of the Ministry of Health. So situating HTA, which is also an evidence-generating activity within that space, looked quite feasible, and that is where it has been to date. In terms of what Ghana wants to do with HTA, we want to be able to prioritize amongst various policy options. We want to be able to select health technologies, including medicines, and that is why we said that we started with application in medicines, but we've scaled up to policy options, we've scaled up to benefits package updates, and so on and so forth. We've even scaled up to even apply it in pricing. So these are the 5 areas. We have procurement and pricing, essential health services, benefits package design, selection of health technologies, and policy prioritization. The good thing is that these things are not in abstract because all of these functions, you can identify key points of decision making where these things are happening, and that helps us in Ghana. So we set up a clear strategy that we want to strengthen the science and practice of HTA to ensure that there are evidence-based decisions in the health system. And to do that, we needed to establish structures, as I've said, build capacity, strengthen the production of HTA, and apply it to optimize resources. Now, in terms of the strategy, there are 9 strategic areas. We have a topic selection that encompasses all the technical work that is done for the analysis. The previous presenter spoke about how challenging to get analysts to actually produce HTA, and it's quite a critical step in the HTA process. So we have a whole strategic area for that. We have a section for manuals and guidelines, the processes and things are all there. Resourcing and tooling for the conduct of HTA, mobilizing resources, communicating the findings, both upstream and downstream communicating. Upstream, you need to communicate all the way to Parliamentary Select Committee on Health. Downstream, you need to communicate to even the end users. Collaborations and partnerships are key. And of course, capacity building is linked to technical work, and that is critical. At the center is governance, the governance structure I showed you on the previous slide. So this is what our strategy seeks to do. Now, in terms of a process, we have this 8-step process in Ghana for HTA. I'll expand on this later, but we nominate topics. We go through a criteria to select the topics that are important. The topic nomination can give you a lot of topics, but then we go through a criteria to scale down to bring the topics of potential high value. Then the steering committee approves that. Then we scope the topics to structure the topics into scientifically answerable questions. Then the analysis comes through, and then the results are appraised, and then the steering committee deliberates on the recommendations, and those are communicated. Of course, if any stakeholders have issues, they are going to appeal. So far, we've not had any appeals yet, and then it's passed on to stakeholders for implementation. This is the criteria for our topic selection. We look at about 5 things. Potential users of it or who will benefit from the technology, the benefits compared to existing technologies, the household economic impact, equity, potential for cost effectiveness. So these are the things that we take before we are able to say that this is a topic worth investing in terms of the cost of time and resources to produce an HTA. Now, when the results are out, the results come up because we have data. It summarizes data on efficacy or effectiveness. It summarizes data on cost effectiveness, summarizes data on equity, feasibility, and all of that. So the decision making or the application of that evidence, at first we said that, okay, so is the evidence that's coming from the HTA, is the technology or is this policy option safe? If it is not safe, then if we touch it at that point, and we don't even progress to look at any other thing. But if it is safe, then we look at then the effectiveness data. And if it is not effective, we also exclude that. But then if it's effective, then is it comparable to an existing technology, or is it better than existing technology? If it is comparable to an existing technology, but then we look at the cost. So is it cheaper than the existing technology? If it's more expensive than the existing technology, exclude. But if it is less expensive than existing technology, then we say that it's eligible for inclusion. Of course, if it's effective and it's also cost effective, then it's also included. Now, the other soft issues around the things that are not exactly quantitative or that are subjective and requires much more deliberation are issues on feasibility and severity and all of that. Of course, there are quantitative aspects to this, but these dimensions are left for much more deliberative discourse within the steering committee. So they use that evidence as well, but in a more deliberative process. Now, we've also realized that this process outlined here, of course, it follows the standard. I mean, if you look at global literature, I mean, these are steps that are standard when it comes to the HTA process. But we have found that decision-making is fast and high-paced. And to go through all of this when politicians are waiting for results to take decisions has been difficult in our setting. And I'll give you some instances. So we had to look at adaptive HTA. How can we adapt existing HTAs? How can we make the process shorter and faster? So then you can see that we have a full HTA and we have a rapid HTA. We leverage our rapid HTA step to actually do this work on diabetes, which adapted existing HTA to the context of Ghana, trying to make or be more responsive to decision makers. And we are documenting that in the form of a guideline in our context that actually makes us faster in terms of the methodological considerations that we look at when we are adapting existing HTAs, all in the effort to be responsive to decision makers. Else you realize that you are doing all the work, but you can't impact decisions because the decisions will move ahead of the analysis. We have a reference case, of course, to guide our methods. And this one, I'll leave it for when you have questions, then we can go deeper into it because there are a lot of dimensions in here in terms of the methodological standards that we look at. I will maybe recommend that you look at that document in much more detail because we've taken a lot of time to actually go into depth with the specifications of the domains. The number of HTAs going on in Ghana, you have hypertension, Beckel lymphoma. These ones have been done already. I've showed you the diabetes one. I'll highlight something on carbetocin for PPH management. These other ones are also work that are ongoing. And there are more coming up. So we have a number of, in fact, we have a lot of work that we have to embark on. And we also have an additional 40 topics. Now it's 38 because we've tried to clear 2 of them. out of direct analysis to prioritize which areas of our health insurance can benefit from efficiencies, technical efficiencies for that matter. And these are the 40 areas. And we started with cleared anemia out, and we are moving on to the next for the 2 top priority ones. And then we continue to dig into the 40 to do the others, just to explore efficiencies within the health insurance. In terms of application of HTA in Ghana, we've done for hypertension. You know that already. I'm sure a lot of you have read about that. But then we prioritize calcium channel blockers and diuretics through this HTA in our response to hypertension management. Then for childhood cancers, we prioritize the policy option of reimbursing for childhood cancers over not reimbursing because of this evidence. Then for pneumonia management in children, we prioritize dispersible tablets over suspensions because of this evidence. And that's currently, as I speak with you, that is being reimbursed. There's a database of the health insurance indicating dispersible tablets where the red arrow is being reimbursed for pneumonia. So this decision has gone live. Then for carbetocin, in addition to oxytocin for PPH management, now the PPH guideline has been updated to include carbetocin, informed by the evidence that came from the HTA work. But then the reimbursement step is still pending. We are still engaging the insurance to reimburse for that. So we have the first step as in update of guidelines. Now there are challenges, and I want to highlight one challenge and look at it. While all of these application cases are very successful, some are also ongoing. There's one particular HTA that we had challenges with, and it's the issue of COVID vaccines, which was a highly politically sensitive item. And that one, the evidence did not really impact on decision-making as at the face value. And we launched an inquiry into this to try and find out why it was so. So the question was, why did implementing stakeholders not use that particular HTA? And there were consequences, okay? So if they are not using it, that means that there could be suboptimal prices, there could be lower quantities of vaccines purchased because they are not being efficient, there could be limited coverage due to fewer quantities provided. We could speculate some of the underlying problems, but that is what the subject of the research was. When we identified, or when we did the analysis of the data, it was a purely qualitative data, and we realized that these 6 things are the issues that were underlying non-application of HTA results. That timing and access was an issue. In fact, I will explain this on the next slide in much more detail. Okay, so in terms of the synthesis, when we analyzed the reasons why some of those HTA reports did not translate into decisions, this is what we came up with in terms of the causative underlying issues. So the first issue is timing and access. That when you do an HTA, the timing of producing that report is critical. And then also access to the content. People must have access to the report and have it on time. Then the technicality of the content. I mean, we are talking about reports that contain clauses like we conducted probability sensitivity analysis, we did deterministic, whatever. I mean, these could be technically dense for people who don't have the kind of background that health economists have or the evidence generators have. And we write our technical language. So that kind of complexity can be a barrier for application. Then the relevance of the context, of the content. How is the content relevant to the decisions that they are making? Have you really delved into the decision problem deeply? And is the evidence actually addressing? It's a nice report, very technical report, nicely done, methodologically sound and everything. But is it answering the need for evidence for decision makers? And that's important. Now, all these 3 things will affect the responsiveness to research findings. Now, the 3 things that I mentioned are things that are related to the HTA process and the way it generates evidence. But there are 3 things also that are not affected. They are environmental things that do not are not really part of the HTA process itself, but they affect the uptake of HTA findings. I'm talking political considerations, that evidence is not the only thing that's looked at in decision making, for instance. People look at other things. Decision makers look at political expedience. and all of that is part of the decision making. And then also health system fragmentation. If you are not clear about who is making decisions on what, and decision making is fragmented within a health system, it affects the uptake of HTA finding because your evidence comes and there's nobody who feels mandated or key responsibility to act on their findings. So that is also a cost. And realize that all of these things affect the responsiveness of the actor to research findings or to evidence from HTA. So based on this, we decided to intervene and improve our HTA process. So you already have seen the HTA process as per global evidence, but we've come up with this manual that improves that process further. The step one is that we need to analyze our key stakeholders properly to identify key decision makers and their needs. It's a way of drilling down to the decision making that is very important. At topic nomination, we've refined our approach to topic nomination. At the step 3, we at the point where we are engaging decision makers, we develop tools to enrich our process to ensure that we drill and we keep decision makers updated in the process very closely. Now, in terms of improving timelines and responsiveness, we are developing prototypes so that not every analysis starts from scratch, but there are tools and digital tools, prototype Markov models, rapid analysis tools that you can use so you turn around an HTA process quickly. And then you also summarize the findings in a one page in language that everybody can understand. That is normal language summaries, 1 page. And then also to support continuous cross-sector collaboration to ensure that everybody is on board. And of course, the uptake of HTA is not only the challenge, there are other challenges, and it includes sustainable funding. We still have that as an issue, trying to crack our heads around that. And we think that there is still opportunity in law to support some of the challenges that we've seen. So I will end here, and then if you have questions, you can ask. Thank you so much for having me.
Nice clap for that section. Very eye-opening. And was he answering some of the questions you were having from morning? Yes? Yeah, I think as he was presenting, I could pick out some of the questions that were being asked. Nancy, has Dr. Asare given you energy to walk the HTA journey, or he has dampened your mood because there's so much that needs to be done? You can ask a few questions. If you have a question, just raise your hand, and then you can ask. It's a learning process. Ghana has taken several steps ahead of us. So we have a firstborn that we can learn from in the African continent. Other countries are also in the same journey. We are happy to learn from you, Dr. Brian. Any questions?
Thank you for the presentation, Dr. Asare. My name is Jeanette Dawa. I work with Tabitha. One of my concerns is, first of all, I appreciate the knowledge that you give us that is not typically taught in class. It's from experience, because typically we learn about a HTA, but you don't learn about these other things that can affect how well the HTA process is taken up, or the outputs of the HTA are taken up. Now you bring up something which also our previous presenter was talking about, the responsiveness to policymakers. And not just in HTA, but even, I think, with other scientific things that we do, we seem to be compromising on the scientific rigor in order to accommodate the politics or our policy makers. And I wonder if that is really the way to go going forward. Is it that from the very beginning, our scientific rigor was not in touch with the realities? Or is it that we need to delink these scientific decisions from the politicians? Because now we are trying to shorten the HTA process, and I'm sure there's a compromise in doing that. So just your thoughts about it, because I'm seeing it not just in HTA, but in other things, that we are quickly trying to respond to policymakers because they want to come out to the public and say, we are doing this. We are giving free this to all mothers. But the HTA behind it, they don't want to wait for that output. So if we rush the HTA, are we compromising on our quality or our output?
In fact, great question. I love this question. I wish I could respond to that before we add on, because that is quite heavy. It's loaded.
Please go ahead and respond.
Okay. So, I mean, you nail the issue to raise that question. And the issue is that you have decision making is coupled with time. So some decisions don't have the luxury of waiting for 6 months. And that is the reality of the policy space. So if there is a need for evidence to inform a particular decision, and the evidence is not forthcoming because, let me say that, because it has to go through a lot of scientific rigor, trust me, decisions will be made with or without evidence in the policy space. You see, so the question is, do we provide some evidence, or do we leave the decision-making space to share guts and to share instincts, where there's absolutely probably no evidence informing them? So it's between the devil and the deep sea. Are you able to provide some evidence at least? So this is what is pushing the HTA processes to be made. And I want to underscore the point. It is not really about reducing the scientific rigor. It's just about time. It's a time issue, not a quality of evidence issue. So our point earlier is that we are, one of the steps in the guideline is that we actually, when a decision is being made and requires evidence, we want to sit with the decision maker and look at what is at stake here. Is it the fact that you need to make a decision in 3 weeks? And if you don't make that decision in 3 weeks, what do we get to lose? Are we able to negotiate and say, okay, fine, we can give you better quality evidence in 2 months? Would something be lost in 2 months? You see, so if you can agree with the decision maker and engage them and actually assess the situation, sometimes decision makers feel that we need to make the decision now, else the whole world is coming to a halt. Meanwhile, when you actually engage them objectively, they could actually make the decision in a month's time and nothing will be lost. So all of that must come into that discussion. So you agree in terms of the time expectation for the evidence and what is also feasible to generate scientific evidence that is of an appreciable quality. Now, if you're able to do that, then you've agreed. So the user of the evidence is expecting results in, let's say, a month. And then you also have an extent of 1 month. What can I do with an appreciable level of quality? But it's much deeper because, like I told you, you are now having to then produce or generate rapid analysis tools that will help you to generate evidence or run some of the HTA analysis faster. And it's possible. Look, there are tools that now can help you do a systematic review faster. There are tools that will help you do economic evaluation faster. And it does not necessarily mean that you are reducing the quality of the evidence. You are trying to be fast. Because at the end of the day, if you came up with the best of evidence, the most scientifically solid evidence, but the decision had been made 1 year before you came with the evidence, then what is the value of the evidence? The evidence generation then becomes a waste of resources, and you don't want that. So I think that is the key issue here. We can take more.
Training. Dr. Jared is bad on time for the pharmaceutical benefits package. Any question for Doc?
No, not a question. I think just a comment that first to appreciate the presentation and probably to follow up later for a more specific engagement around the pharmaceutical package for Ghana and the HTA process that led to that. So Doc, we will be probably following you up to have some other engagement around that. But maybe you could briefly speak about it. I saw already the involvement with some of the medicines and the choices around diabetes, hypertension, etc. But broadly speaking, around the medicines that you use and you reimburse, maybe just a comment around that. But I think we'll follow up with subsequent engagement.
Okay, great. So for our, when I'm talking, I'll turn on the video so that you hear me well, so don't worry. So the issue with the pharmaceutical has to do with the fact that we've done a lot of analysis that actually updates the reimbursement package for our health insurance in terms of new cost-effective alternatives to existing drugs that will be put on the benefits package basically. But we find that a very easy process because prices on drugs are easy to get. Utilization of drugs data is easy to get. Um, um, Equity data is easy to get. Outcomes data is easy to get. Even efficacy or effectiveness data is also easy to get. So, I mean, that is why we seem to be moving very fast there. And we've also made a lot of impact in that area. We find it as a low-lying fruit because in our health system in Ghana, a lot of the foundations are established to be able to apply this in the area of medicines. But as we get into the other areas, for instance, the decision to reimburse childhood cancer or not, and then decisions to adapt certain kinds of policy options over others, those ones, you realize that you have to go in a bit more deeper in terms of the data challenges. So this is maybe a little bit of a short briefing, but the process of updating our EML has benefited from this. The process of reimbursement medicines have benefited from this. The process of guideline updates have benefited from this. The process of price negotiation have also benefited from that. Over. But of course, we can go much deeper, as you have said.
I think we are at our lunch hour, but just before we break, and if there's no any other question, I have just one question for you, Dr. Sari. I saw in your presentation you have about 40 topics that have been prioritized for HTA. Some have already undergone the HTA process. Some are ongoing and others are still pending. What time, like how much time input goes into that process that some will be pending, and how have you planned for your time for that to, for the whole HTA process to be undertaken for the topics that you have prioritized? Also, how did you get to the 40 topics? Did you have 1,000 topics that were proposed, and how did you narrow down? Or did you just pick the first 40 which are high budget impact? Just take us through that process, then we can have our break.
Thank you so much again for that question, brilliant question. So those 40 topics, this is how we got about them. We picked the top cost drivers for our health insurance, and then we analyze in an ABC Venn analysis what the 20% that is costing the 80% of the budget is for health insurance. And that is what we translated into those 40 questions. So that is how we got the 40 questions. So in optimizing those 40 questions, we are actually optimizing 80% of our insurance claims load. And that is one. Number two, when it comes to timelines, the truth is that we have not really put timelines there because we are so much dependent on the availability of resources to do those particular topics. So we are actively rather looking for resources. And for the first two, we're able to pick the first two because we're able to identify some strategic partnerships that will help us to implement those ATAs. So it comes back to underline or emphasize the challenges that I presented on funding and sustainable funding, which is very critical. We are not able to commit to the time because we don't have the dedicated resources to do this. We are now still making advocacy with our governments for HTA to be centrally funded. Now we are not there yet. So we still leverage our partnerships, we still leverage our networks to get funding to support these HTAs. And over time, we are also trying to reduce the cost of production of the HTA by using internal capacity, internal resources, looking within so that the cost of production is actually low.
Thank you. Thank you so much for that response. I think we have...
Low. So we can...
We lost you. We lost you, Dr. Asari.
No. I was trying to check whether there was a third aspect of the question that I answered two aspects of it. But if you're okay, then it's fine.
I think the last one, you pretty much responded to it indirectly by how you selected the topics. Thank you so much for your time and for making time to share with us your experience. We hope that you will be ready to engage with the Directorate of Health Products and Technologies, the Ministry of Health, and help us to collaborate and learn so much more from you as we keep reaching out. Thank you so much for your time.
Thank you so much for having me. Thank you.
So that marks the end of our morning session, and we'll take a break now and proceed for lunch. Are we able to come back by exactly 2 o'clock? We try our best to be here by 2 o'clock, right? Yeah, we have one more pending session from the morning session before we can do our exercise. So if you can keep time, I think we'll be able to leave on time. Thank you so much. We didn't have the officials for praying for lunch, the governor, the timekeeper. You'll help us to identify as we go. So maybe